Hello guys, now we will do a respiratory examination and we will start with the chest examination. The first we will see the topography of the chest and the shape of the chest. Generally we have normosthenic patients, but they can be asthenic and hypersthenic. So when we look at it, we have to determine what kind of the chest looks like, either it's normosthenic, sthenic, or hypersthenic. Okay, we are going to do respiratory examination, and we will start with the static inspection of the chest. In the static inspection of the chest, we have to conclude what is the chest, either it is asthenic, normosthenic, or hypersthenic. So to find out this, we will start inspecting from the supraclavicular hollow and the subclavicular hollow. If they are like in the medium range, we will say that they are normosthenic, and if they are increased and very visible, they can be asthenic, and in the hypersthenic, they are below normal or below medium. And after that, we will see the intercostal spaces. If they are about 2 centimeter, they are normosthenic, and otherwise, if they are increased, they are asthenic, and decreased, they will be the hypersthenic. And after the ribs distance, we will go next to the next क्या था? And after the intercostal space, we will see the shape of the ribs. If they are like oblique, they are the normosthenic, and if they are like the vertical, they will be the asthenic, and if they are like too much horizontal, they will be the hypersthenic. And after this, we will see the length of the thoracic part compared with the abdominal part, and if the length and the volume of the chest is equal to the volume and the length of the abdomen, then the patient is called to be the normosthenic. And if they are increased area of the abdomen, area of the chest, then it will be the asthenic, and if the area of the chest is decreased, then this will be the hypersthenic. And then we will look at the epigastric angle. To see the epigastric angle, we have to put our both hands like this in the epigastric, and in the normosthenic, the angle between the two thumbs will be the 90-degree angles, and if it is increased, then it is the asthenic, and if the angle is decreased from the 90 degree, then this will be the hypersthenic. And the last thing which we have to see in the chest examination, the static chest examination, we have to ask the patient to turn back side. Okay, can you please turn back side? Yes, and stand up. And in the back side, we have to see the shape of the scapula. For this, we will ask the patient to put our hands on in this shape. Can you put your hands like this? Okay. Now we can see the angle of the scapula. If the angle of the scapula is normal, then the patient is the normosthenic, and if it is winged, then it is asthenic, and if it is not visible, then the patient is said to be the hypersthenic. So this is the static examination of the chest. And now we will move to the dynamic examination of the chest. In dynamic examination, we mainly have to see the breathing pattern of the patient. First, we have to see the movement of the chest is normal, like the both sides are moving normal, and the patient is having no difficulty in breathing. And so we will ask the patient to breathe normally. Can you breathe normally? So in this state, we can see both the left and the right side, they are moving in sequentially, no difference in the moving, so there is no paradoxical movement. And the next thing we have to see, the rate of the breathing per minute. And to determine this, we will count the number of the breaths per minute, and we will ask the patient to put his hand on the belly. Yes, like this. And I will start counting the breaths per minute. And if the breaths are like from 16 to 20 per minute, then the patient is normal. And if the breaths are like less than 16, then we will say that patient is having the breath apnea. And if like more than 20, then it's the tachypnea. So in this case, the patient is very well, normal, and the breathing is normal. And so pause please.
Action. Action.
So in dynamic inspection, we also have to see, we also have to mind the gender of the patient. If the patient is male, then we can see the dominant breathing is from the abdominal part, and in female gender, the dominant breathing is from the chest area. So but in the children and in the elderly patient, whether it's male or female, the type of the breathing will be the mixed. And also while doing the static inspection, we also have to uh, see the type.
Action.
While doing the chest inspection, we also have to look for the chest pathologies like the barrel shaped chest and the shape of the mediastinum and the sulcus, like the horror sulcus or the pigeon shaped like chest. So we have to keep in mind all of those pathologies. And the next we will move to the palpation of the chest. So to do the palpation, we will start from the supraclavicular, subclavicular, the first intercostal, and we actually touch the patient from these areas, and we also see the pectoralis area, and throughout all of the frontal chest and the lateral side and the back side. And we also will look for the lymphatic nodes. Is there like if there any lymphatic node is swollen, or is there any place which is like painful on touching? So we will do this palpation like in this manner, like front, lateral, and then the back side. And from the back side, we will start from the C7. Okay, while doing this palpation, make sure that you check from these major landmarkers like the sternum area and the parasternal line which goes this, and medial clavicle, and then the axillar and the medial axillar line, and from the back side the angles of the scapula, the vertebral line and the paravertebral line. And also check the intercostal areas for any kind of like pathologies. And after this we will move next to the voice trembling. We will put our hands on the specific areas and ask the patient to speak words like 66. Like we will start from the supraclavicular and ask the patient to speak 66. Can you please speak 66?
66.
Okay. And in this, we will feel the vibrations of the voice of the patient. And first, we will put hands on both sides and ask the patient to perform 66. Can you know?
66.
And in this position we will see the voice intensity is similar and normal on both sides. If there is any kind of voice difference, we can see we can identify a kind of pathology on either side. If the resonance is clear, then there is no pathology, but if it is dull, then there might be a chance of any kind of pathologies on that side. So after this uh, uh, we will go to the parallel to the clavicle on the both sides, and then we will ask the patient in the armpits and the axillar area, and inner scapular area, and also to the scapular area. So this will be the end of the palpation.
Action.
And the next we will come to the in the chest examination we will do the percussion. And percussion is of two types. First is the comparative percussion, in which we identify the sounds, if it is the clear sound, then there is no pathologies, and we will do it in the same manner, like the supraclavicular, subclavicular, intercostal spaces, and like it goes on, like the palpation. And the other kind of the percussion is the topographical percussion. In topographical percussion, we actually figure out the landmarks like the apex, lateral sides, and the lower end of the lungs. And we do the percussion, and we start from the supraclavicular area, and where we have the clear sound, we say it's the apex of the lungs, and we goes by different lines, and on different lines the position of the lower end of the lungs is different. And for example, in the parasternal line, it is the fifth intercostal area. But if we see on the back, the by the scapular line, which is just posterior to the this line, it is on the 10th rib. And while doing the percussion in the topographical manner, we have to skip from after the third intercostal space on the left side, because there is heart and we do not percuss on the organs. And while doing the percussion, we will do like this. We put our two fingers like this, and we do this like tuk tuk. And every time we do this, and if we hear the clear sound, there is no pathology. But in type of there is any pathology, we will have a dull sound. And also, while doing percussion, we have to know the excursion of the lungs. And for doing the excursion of the lungs, we will ask the patient to breathe in and out. And we will first choose a line of our action. Like for example, if I choose like the medioclavicular line, the percussion will be different, and by the scapularis or the mediascapularis line, the percussion will be the different. So for doing the percussion, first I will ask the patient to first I will do the topographical percussion, and I will find the lower end of the lungs, and I will after finding the lower end, I will put a mark on that area. It will be the lower end of the lungs, and then I will ask the patient to breathe in as much as he can, and then I will do a second marker which is lower to the end of the border of the lower border of the lungs, and then I will ask him to breathe out with full force. So I will do another marker which will be the top on the lower end of the lungs, and then I will measure the distance between the most upper marker and the most lower marker. And if the distance is between 4 to 6 centimeter on the medial clavicular line, then the patient is having normal extension of the lungs, and this distance is different on different line. For example, on the medial axillary line, the distance will be from 6 to 8 centimeters. Okay, last step in the chest examination is the auscultation of the chest. In auscultation of the chest, we will use stethoscope, and there are two types of auscultation. One is the vesicular, and other is the bronchial. In vesicular, we have the sounds of the we uh, do the vesicular auscultation on the area of the surface of the lungs. And in this auscultation, we will start from the supraclavicular, then the subclavicular, from the apex of the lungs, and then first intercostal space by the
Why don't you just action?
okay, so we will use now the stethoscope. And
Okay, now it's too noisy.
for the auscultation, we will use the stethoscope, and we will start from the apex, from this area, or the top of the lung. And after this, we will do the second intercostal interval by the parasternal line. Here, if this is sternal, this is the parasternal line. And the third auscultation we will do on this side. And after this, we will move to the third intercostal interval by the medial clavicular line on this side, and then on the parallel side of the second right side, and then we will move downward in this direction. And the fourth one will be the medial axillary anterior view, this side. And after this, we will go to the left side of the patient on this area, and then we will do the medial axillary posterior line on the same area from this side, and then this. So in the same way, on the back side, we will do like the apex of the lung from the back, from the area starting below. Okay, on the back side, we will start from this area C7 and the apex of the lung, and we will move to the other side. And after doing this, we will see this is the border of the, and we will do like this. And meanwhile, we will ask the patient to breathe normally, and we will hear the sounds of the breathing. The breathe in will be the 2/3, and the breathe out will be the 1/3 of the whole sound of the breathing. And we will do this interscapularis area, and then we will move to the subscapularis area, and we will do on this both sides, like parallel to each other, left right left right left right, and no, actually left right then left. And we will do this percussion to the subscapularis area until the ninth rib. And the other auscultation of the lungs, it constitutes on the neck region, the bronchial auscultation. And for this, we will ask the patient to face the doctor. And the bronchial auscultation is usually happen on three areas. The first area is usually on the throat, the area on the larynx and the trachea. And if there is any kind of obstruction, we will hear the sounds in this area. And the second is the area of the bifurcation of the jugular veins, like in this area. On the both sides, we will do this auscultation. And the third is above the bifurcation of the trachea, which is along this area. Okay, from where the bronchus are the bifurcate from the trachea. And we can also, while doing this auscultation, we can also ask the patient for the bronchophony. And for the bronchophony, we will ask the patient to say 66 loudly. So if there is no sound, the patient is okay. If we hear any sound, there can be a pathology. And besides that, there are accessory sounds, three types of accessory sounds. The wheezing, which is the bronchial sound, we will hear on the in the bronchial auscultation on the neck, bifurcation of the jugularis, and the bifurcation of the trachea into the bronchus from the left and right lungs. And the other two sounds, they are the vesicular sounds, which we will hear them on the surface of the lungs in the vesicular auscultation. One is the crackles, and the other one is the pleural crackles. The pleural crackles, they will be the hearable in this area more on the pleural side, and the crackles, we will hear them on in the medullary sides.